Atrial fibrillation is the most common sustained cardiac arrhythmia. It is defined by rapid, disorganized atrial electrical activity, leading to loss of effective atrial contraction. The ventricular response is irregularly irregular due to variable AV nodal conduction. Heart rate typically ranges from 110 to 160 beats per minute, but may be slower or exceed 200. Triggers include ectopic foci mainly from pulmonary veins, as well as the superior vena cava, coronary sinus, and vein of Marshall. These ectopic beats initiate fibrillation. Atrial fibrillation progresses from paroxysmal to persistent, and then long-standing persistent forms. This reflects increasing atrial remodeling and fibrosis. Electrical remodeling shortens refractory periods and promotes abnormal automaticity. Structural remodeling leads to atrial fibrosis and left atrial enlargement. Risk factors include hypertension, diabetes, obesity, sleep apnea, alcohol use, myocardial infarction, pulmonary embolism, pericarditis, and cardiac surgery. Atrial fibrillation prevalence increases sharply with age. It affects about 10% of individuals over 80 years and carries a lifetime risk of around 25% in men. Clinically, patients may present with palpitations, dyspnea, fatigue, presyncope, or syncope. Loss of atrial contribution reduces cardiac output. Complications include thromboembolism from the left atrial appendage, tachycardia, induced cardiomyopathy, and progressive heart failure. Diagnosis is confirmed on ECG by absence of P waves and an irregular ventricular rhythm. Continuous monitoring may be required for intermittent cases. Rate control is the first management strategy in many patients. Beta blockers, diltiazem, or verapamil are commonly used to control ventricular rate. Target heart rate is generally less than 80 beats per minute at rest and less than 100 during light exertion. Digoxin is used less frequently today. Rhythm control is considered for symptomatic patients or those with ventricular dysfunction. Antiarrhythmic drugs include Class 1C and Class 3 agents. Catheter ablation targets pulmonary vein isolation. Success is about 70% after one procedure in paroxysmal atrial fibrillation and higher with repeat procedures. Stroke prevention is guided by CH-ATDS2 VASC scoring. Anticoagulation includes direct oral anticoagulants or warfarin in valvular disease. Lifestyle modification is essential. Weight control, blood pressure management, alcohol reduction, and sleep apnea treatment reduce recurrence. Key clinical principle is integrated management combining rate control, rhythm control, and stroke prevention. Treatment must be individualized based on symptoms and risk profile.